I have the pleasure to introduce, last but not least, Madeline Wunder, who is a physical therapist, a colleague of mine and ours in the department. She's our newest addition to the department. Is a great addition. She's a very, very talented young therapist and will do great things in her career and great things for Plymouth Bay Orthopedics. I'm sure of it. She's going to be a little embarrassed when I tell you this, but she is the only doctorate degree in our department, so you can call her Dr. Wunder if you want to. All right, Maddie, you ready?
So thank you, Dave, for the introduction. I'm going to be talking about post-concussion syndrome, so just a little bit different than what Dr. Turan and Erin were speaking about, and I'm going to be doing it from a therapist's perspective. So just some quick objectives that I'm going to go over in regards to my presentation. So I'll define post-concussion syndrome, discuss the 6 different domains associated with that. Dr. Turan already alluded to that, and I'll expand upon that a little bit more. The evaluation and treatment of the PCS patient, PCS, the abbreviation of post-concussion syndrome, as well as current return to play guidelines. So this right here is the consensus statement on concussion in sport group, or what they abbreviate as CSIG. So every couple of years, the masterminds of concussions get together, review the latest information, come up with new statements. And so this is the one from 2016, and they have defined it as a traumatic brain injury induced by biomechanical forces, and it may be caused by a direct blow to the head, face, neck, or somewhere else in the body, but with an impulse that's transmitted up to the head. All right, everybody, pop quiz. So let's get some audience participation here. I want a show of hands, A, B, or C. So after a concussion, which symptom places the person at a greatest risk for a prolonged recovery? So can I get a show of hands for A, dizziness, B, headache, or C, loss of consciousness? And how many people didn't raise their hand at all? Okay, good. All right. So the correct answer is actually dizziness. Okay, you wouldn't think that it would be. However, this is an article from the American Journal of Sports Medicine back in 2011, and what they were looking at is they wanted to know which sign or symptom predicted someone who had a prolonged recovery after a sports-related concussion. So what the study did was they wanted to find which of these symptoms allowed that, and they included 107 male high school football players. They completed neurocognitive testing within an average of 2.5 days after their injury, and they followed them all until they returned to play fully symptom-free. And this article found that dizziness at the time of injury was the leading symptom of someone who had a prolonged recovery. That's not to dismiss, of course, if anybody has headache, loss of consciousness, any of those other symptoms. However, if someone does report dizziness at the time of injury, just something to kind of keep in mind that these are the ones you really want to watch out for. So when is it considered post-concussion syndrome? 80% of concussions will resolve within the first 21 days, 3 weeks, without any medical intervention. So if you were to take a sample of 100 people, 80 of them would get better in about 3 weeks. 20% of them remain symptomatic after 3 weeks after their date of injury. When they have symptoms really 14 to 21 days, but greater than 21 days, that's when we consider it post-concussion syndrome, and that's when we really start to see some more of these athletes in our clinical setting. So some risk factors for those people who will have a prolonged recovery: people who have ADHD or a learning disability. Everybody could probably guess this, but a history of greater than 3 prior concussions or subconcussive hits or injuries you've had, it's probably going to take you a little bit longer to recover. Any sort of a psychiatric or mood disorder, and or a history of a migraine at baseline. So Dr. Turan had already touched upon this as well, but this is from the University of Pittsburgh Medical Center, and these are the 6 different concussion domains. So what this means is after someone's had a concussion, usually they will exhibit symptoms not in just one of these 6 categories, but they'll be in multiple. So you have vestibular, ocular, your cognitive fatigue group, post-traumatic migraine, cervical, and anxiety mood. There's no one size fits all. After someone sustained a head injury, they're not just gonna have symptoms of ocular, they're gonna have multiple different symptoms from the different domains. And physical therapy intervention, what we're concerned with, is beneficial for the subtypes of cervical, vestibular, ocular motor, and the cognitive fatigue group. So I get this question a lot, where how do you evaluate the patient with post-concussion syndrome? It's similar in in sorts to any other orthopedic PT evaluation, I think everyone in this room can agree that if you get a really good and thorough subjective history from your patient, that will tell you a lot in regards to the patient's care, what's going on, their symptoms and things like that. However, with this patient group, subjective history is key. I spend a lot more time in the subjective part of these evals than I do anything else with this patient group. Things that you want to ask but not limited to: are you having headaches? Did you have a headache after the time of injury? Do you have dizziness? Did you have a loss of consciousness? Do you remember if you had a loss of consciousness? Do you have any light or sound sensitivity? By the time they're in to see us, are you in school? Are you still not in school? Are you doing a half a day of school where you have to, sit out of math and physics class and things like that? Are you sleeping okay? A lot of these patients also have issues where they're not sleeping well. Are you somewhat back to sports, participating lightly? Glasses. Do you have glasses and or wear contacts at baseline? Have you had an eye exam or an eye consult? This is a big thing that I'll see a lot of times in the clinic, where if you have a patient who has contacts and or glasses, if they're having any sort of ocular motor disturbances after an injury, if they haven't been back to see an eye doctor, I will recommend that, because there can be some changes where even just changing a glass prescription or a tint or something like that can make a big difference for this patient group. And some objective information that you'll also get, but not included to: cervical and shoulder active range of motion. You want to do reflex testing, test their cervical and upper extremity strength. You want to do ocular motor, vestibular, balance and proprioception testing, palpation. The biggest thing, and I would say the trickiest part when evaluating these patients, is a lot of times you have this whole idea of things you want to do, this huge list of things you want to look at, but the patient can't tolerate all of that. Sometimes as you start to test them, it will provoke more of their symptoms, and so oftentimes you kind of have to tease out what you find is most important, because they can get pretty symptomatic pretty quickly. So Dr. Turan had also already alluded to this, but I love this, the VOMS, or the Vestibular Ocular Motor Screen. This is developed from the University of Pittsburgh Medical Center, and it's great because it's really short and quick, and you can capture a lot of information about these patients in a really short amount of time. So in terms of things that you're looking at when you test this, you're looking at smooth pursuit, horizontal and vertical saccades, you're looking at convergence, which is the eye's ability to hone in on a gaze while you're moving something closer towards you. Horizontal and vertical VOR, or the vestibular ocular reflex, and VMS, which is visual motion sensitivity. And so what you're doing when you're doing this exam is you're looking how this patient's symptoms change or exacerbate when you're testing them. This test is great for subjects age 9 through 40, so if you're really looking at that sport-related concussion group, this is really good for them. So this is kind of the screenshot capture of what you're looking at when you're testing them. You want to ask these 4 questions before you do any sort of the testing. You want to ask if they have any headache, dizziness, nausea, or fogginess on a 0 to 10 rating scale. And then as you go through these different tests, you're going to ask them those same questions every single time to see how their symptoms worsen, stay, okay, they don't become symptomatic. And what's nice is when you're done with doing this exam, you get a nice little chart with numbers in front of you that gives you a lot of information in a short amount of time. And a way to interpret this, so if you have a near point of convergence greater than 5 centimeters, so as I kind of mentioned before, the near point of convergence is if you were to take, like a small X on a tongue depressor or a little eraser on a pencil, you bring it in towards the patient's nose. When that target doubles, you measure that distance, and that's your near point of convergence. If that's greater than 5 centimeters, you have a 35% increase in the probability that you've identified someone who had a concussion. If you have a symptom score of greater than 2 on the 0 to 10 scale on any of those VOMS items, you have a 50% increase that they've had a concussion. And if they have greater than or equal to 3 items on the VOMS that they became more symptomatic with, you have an 89% accuracy in identifying those people who have had a concussion. One thing to note when we're treating these patients in the clinic, it's really important, and I always go by what we call the rule of 2 when you're treating this patient population. So if they come in with baseline symptoms of, I have a 2 out of 10 headache today, while we're working on things, if their symptoms go above a 4 out of 10, that's where you want to stop. Any greater than 2 on that scale, you want to kind of scale it back and back it down. You don't want to provoke their symptoms to the point where you've exacerbated them in the clinic. Another thing that I really like to use is the balance error scoring system, or what we call the BEST test. So this is a really good balance and vestibular test where they assess static postural stability. And this test is specifically used for patients who have had a concussion and or a mild TBI. This is the patient group that this was tested for. So the test is actually really hard even if you haven't had a concussion or hit your head. So there's 3 different positions you test them on, even and uneven surfaces. You test it in Romberg stance, single limb stance, and tandem stance. They're all completed for 20 seconds. You have to keep your eyes closed the whole time, no shoes. So you're in, your socks, so to speak. And then the scoring on this test is determined by the number of errors. And there's a way to score it from there. It's a very user-friendly test, and this will also give you a lot of information in a short amount of time. So I like to use this one as well. So the next group I want to talk about is the cognitive fatigue group. So a great test to use for these guys is the Buffalo Concussion Treadmill test. So what this is it's like any other graded exercise test that you would think of, where you're monitoring vitals, blood pressure, heart rate. There's a Borg scale or an RPE scale that you have them do, and you're increasing the incline as you do the test, and you're basically seeing how their symptoms behave and or change as you're doing the test. This group you want to treat with what we call exertional training, where you're basically taking them from the point where they're asymptomatic and you want to push them physically to the point where you want to see at what threshold they start to become symptomatic. Is it at 60% of their max heart rate, 70% of their max heart rate? What happens to their blood pressure when you get them to this certain stage, things like that. And the way you want to progress them is from, like a private treatment room or more of a quiet space, minimizing position changes, head position, things like that, and continue to progress them into all the way back to mimicking sports-specific activity, 85% of their max heart rate, basically conditioning them to get ready to what they need to do on the field again. And then the last thing I'm going to touch upon is the graduated return to sport strategy or guidelines. So I kind of alluded to this already, but if you take a look at this is from that CSIG group, or the Concussion in Sport group. This is from them where they have their breakdown of return to sport and where to go from there. So what we're really focused on through this is getting the patients back to stages 4, 5, and 6. So when they're in to see us in the clinic, we're doing non-contact training drills, we're getting their heart rate up, we're changing head position, we're doing all sorts of things to mimic whatever individual sport they do. Then stage number 5, the biggest thing to note is that when they're doing full contact practice, it says here following medical clearance. So once we think is appropriate to go into stage 5, that would be when we would send them back to either Dr. Turan or Erin or somebody like that to have them repeat their exam, do additional neurocognitive testing like an impact or something like that in conjunction to our testing as well, to then come up with a final decision as to whether these athletes are ready to return to play. And that's it.